All right, so I think we probably should go ahead and get started. So good morning, everyone. My name is Danielle Lauder, and I'm the Program Director of the Northeast Telehealth Resource Center, and I'm going to be your moderator for this session this morning. And I just want to say a big thanks to everybody who has been able to join us again here for this fourth and final week in our virtual conference series. If you haven't participated in these breakouts, just a couple of logistical types of things. We will have Q&A at the end of the session. Our speaker is going to have the vast majority of our time here for the session, but then we will have a live Q&A so that you can ask Kirk or any questions that you might have. And then please use the Q&A function within the app, if you would, to ask your questions ahead of time. And as you know, you can upvote those so we can kind of prioritize the ones that people would really like to hear the answers to. If you do happen to put them in the chat, I'll go ahead and copy and paste them into the Q&A as well, so that we'll have them in both places. So I think without further ado, I'm going to go ahead and introduce our wonderful speaker. Kirk Gillis is Chief Strategist with an Constant Horizon Healthcare Strategy and Consulting Company. In keeping with our usual, we're going to keep these introductions very, very short so that you can hear from Kirk. That's really the important thing that we want to get out of this session. So Kirk is going to be talking about how new normal technologies impact the delivery of healthcare. I'm really excited to hear this session and what Kirk has to say, particularly with the pandemic and how folks are adjusting, and gleaned his expertise in this particular area. So without further ado, I'm going to go ahead and Kirk, take it away.
Danielle, thank you very much. And good morning, everybody. Happy Friday. It's great to see you. Oh, that's right. I can't see you because this is the 2020 virtual telehealth conference. Be that as it may, it's great to virtually be with you from our COVID headquarters here in Denver, Colorado. And as Danielle said, I'm going to be speaking this morning on how new technologies impact the delivery of healthcare.
I've had the opportunity to attend a lot of investment and healthcare technology and industry events over the last few years. And these events have really provided me with a good glimpse into what the future of technology-enabled healthcare might have in store for us. And I just want you to know that although we're going to be looking at a number of solutions and companies over the next few minutes, I do not have any conflicts of interest to disclose. As I just mentioned, the investment activity into healthcare technology has been tremendous over the last few years. As much as $6 billion in 2018, and in 2020, venture capital community is on a $12 billion burn rate in the digital healthcare market. What does this mean for us? I think this means that investors are betting on technology-enabled healthcare to disrupt the status quo, to drive efficiencies and accelerate the creation of consumer-centered care models. And when I talk about digital health or technology-enabled healthcare, telehealth, telemedicine, I use those terms interchangeably. What are we going to cover this morning? I'm not going to try to cover 150 digital health innovations. Rather, I really want to focus on the care continuum and care model innovation, access, quality, and affordability improvements for patients, and productivity, quality, and work-life balance enhancements for clinicians. I'm proceeding so you can click. So many of us in this virtual room, many of us in this industry, I hear this all the time, people talk about wanting to go back to normal. And I think many of us in this virtual room know that we're probably not going back to normal. We're going to move forward to a new normal. And this new normal is going to pose or represent new, unique challenges and problems for the industry, and hopefully we're going to come up with new and unique solutions to address those challenges. Some of these challenges include, how do we produce more with less? I know that we are facing unparalleled financial and human resource constraints, and how do we produce more with less while better aligning clinical expertise with those programs? How do we sustain capital investment strategies while better aligning capacity and access initiatives with the new demand? And lastly, how do we achieve or continue to achieve value-based improvement goals while consumers increasingly prioritize convenience and access? Click. So we're going to start, this presentation is going to walk us through the care continuum, and I'm going to address some of the more traditional kind of telehealth approaches, as well as some of the technology-enabled and digital health innovations that are occurring at each phase of this care continuum. In starting with self-care, what I really want to emphasize here is that the industry has done a great job over the years of providing patient and family and caregiver education and support. With that said, or that being said, much of that education and support was done on a one-to-one. Much of that education and support was done on a one-on-one or a small group basis. And with those financial and human resource constraints that I mentioned a few minutes ago, we need to figure out how do we now expand these programs to be one-to-many. And instead of educating and supporting one patient at a time or 10 patients at a time, how do we support 100? How do we support 500 patients and families at a time? How do we take what we've learned in the last 90 days and scale distance learning best practices to meet the healthcare education and support that families and patients of chronic illnesses and life-threatening illnesses face on a day-to-day basis? Also, over the last 90 days, we've really come to value and appreciate what a healthcare call center or contact center can do for an organization. Many of the people in this virtual room are probably affiliated with organizations that used to handle 100 calls a day, maybe 1,000 calls a day. Well, over the last 90 days, they've been handling, 5,000 calls a day, 10,000 calls a day. I've heard organizations that are handling as many as 30,000 calls a day through this crisis. And we're going to spend a few minutes here talking about how digital health assistants are going to be the new call center or contact center for healthcare. One of these digital health assistants is called Buoy Health. They've been in business for several years now, and there's other companies like Buoy that are building what I call AI-assisted platforms. And these machine learning platforms are consuming more than 18,000 clinical publications and 5 million patient records annually in order to create and maintain and enhance more than 1,700 triage medical conditions. So patients can connect to Buoy. Buoy will have a self-directed decision tree type of approach to how do I manage this healthcare condition. And what makes Buoy and some of the newer digital health assistants more unique is that they actually partner with your local healthcare organization, with your local healthcare insurers, and make sure that in the event that the triage process results in a referral to a provider, that referral is made to a local in-network provider so that patients can connect with that provider and they have the lowest out-of-pocket costs or expenses associated with that transaction. The other thing that Buoy and others in this new vein of digital health assistants are doing is that they're telehealth enabling these AI-assisted platforms. So again, if the triage process results in the need to have an on-demand telemedicine visit, that they can connect you with your provider or a local provider or a provider in your network to address the condition that's being triaged. Another kind of digital health assistant that many of us are familiar with, we've seen the wearables that you put on your wrist, whether it's a watch or a Fitbit or a Garmin band. But this company, Aura, is kind of the latest entrance into the digital health assistance world. And they make these beautiful rings. I've seen these. They're very stylish. And if you can see the slides, the inside of the ring is filled with physiological or biometric sensors. And just like other digital health assistants, these sensors are automatically, passively monitoring you as a person, as a patient, 24/7. And this data is being uploaded to the cloud and into their mobile app, which is called Moment. And you can download this mobile app, at the Apple Store or the Google Play site. And this technology is used to help patients manage and improve their sleep. It's being used by patients and families and caregivers who have suffered from injuries or illnesses to enable them to recover more quickly and be ready for any upcoming activity or events that they need to participate in, as well as your typical fitness tracking and activity tracking and reporting and measurements. What's also nice is that if you are an Apple Health consumer or customer, Aura integrates with Apple Health as well. So whether it's a watch, whether it's a wristband, you now have an option to wear a ring where you can capture and transmit and manage all of your personal health information in a real time, in a synchronous or asynchronous manner. I'm clicking onto the next slide, and now we're looking at the next step of the care continuum, and this is primary care. Probably many people on this call or in this virtual room have either stood up or have expanded their virtual visit programming over the last 3 to 4 months, and congratulations for everything that you've done. As I talk to my clients and other organizations in the industry, I've kind of find that the customers or these organizations fall into 2 categories, or they're at a crossroads. And that crossroad is, do we continue to expand the virtual care programming that we've established, that we pulled together in the last 3 to 4 months, or do we pause and consider a relaunch of this programming, because we need to make sure that the programming is built on a highly scalable, a highly sustainable foundation that may better serve the organization and the community and their patients better in the long run. Either way, when I work with organizations, I really encourage them, if you're going to start or you're going to relaunch or you're going to expand your program, start with scheduled, virtual visits or telehealth appointments. These are easier for the provider, it's more comfortable for the patient, it's easier for the staff, and it leads to a higher likelihood of success for these clinical organizations. Once they've mastered the art of scheduled virtual appointments or telehealth or telemedicine appointments, then maybe they're ready to move on to on-demand telemedicine. And for those of you that have already gone through this journey, I don't apologize for preaching to the choir, but you probably also realize that on-demand telemedicine is much more challenging. There are cultural challenges, there are workflow challenges, there are relationship challenges as far as patients in the community and your organization that need to be addressed. And it takes an organization that's already familiar with telemedicine best practices to really be good at on-demand telemedicine. We've talked about virtual originating sites, patients connecting from anywhere, anytime. One phenomenon, and I heard a little bit on the Q&A that was going on, is occurring in rural health and frontier healthcare communities, where the challenge of recruiting and retaining providers, whether they're advanced practice providers or physicians, is extremely difficult. And in some cases, it's impossible. And I've seen now communities, both in rural and frontier, that are even smaller than rural, standing up 100% telemedicine clinics. And they're using these clinics on a full-time basis or a part-time basis, and they're staffing these clinics with a medical assistant, with an x-ray tech, maybe with a lab tech, and with a nurse, and they're able to connect patients with room-based carts to primary care, urgent care, occupational health and medicine, specialty care, and even mental health resources. So the opportunity is out there, and many of these rural and frontier health communities are getting very innovative as to how they're connecting patients with the medical services they need, regardless of whether or not they can recruit and retain providers in their local community. We're also going to spend the next couple of slides talking about some technology that we're using in these virtual visits today, and diagnostics as a service and digital medical assistance. So I'm going to click to the next slide. Some of you will be familiar with this, and what I hear from clinicians, especially over the last few months, as people have ramped from doing 1% of their volume virtually to 30, 50, 80% of their volume virtually over the last several months, is that the clinicians are really still wanting to have the kind of physiological data and information, having access to the kind of physiological data and information that makes them feel like they can provide a high value, high quality experience for their patient. They want to be able to diagnose accurately new conditions, and they want to help manage more effectively existing conditions. And it's hard to do that if you only have audio and video input. So TytoCare is a company that's been in business for several years now. They have an FDA cleared device that is sold through retailers across the country, and it can obtain and transmit a half a dozen physiological data points to a treating physician in real time. MedWand is a relatively new entrance into this virtual device world. If you're not familiar with them, they have a device that, like TytoCare, is about the size of the palm of your hand, and their device actually supports 9 to 10 the capturing of 9 to 10 different physiological inputs, transmitting that information to your provider, both in a synchronous and asynchronous manner. And MedWand is currently operational and international and offshore markets. Their device is in the FDA clearance process as we speak, and they hope to have the ability to sell and support their product in the U.S. market sometime very soon. I think what these products both represent is that the excitement around the virtual visit concept, and how brick and mortar patients don't have to go to brick and mortar infrastructure to receive a high quality, high value experience. But more importantly, how can we capture and transmit the kind of physiological and maybe biometric information that clinicians need to deliver that high quality, high value experience? One of the things that I'm concerned about relative to this new model, if we're going to deploy these devices, is the economic model. And someone has to pay for these devices. Someone has to pay for the cloud that receives and transmits this information to the provider. These devices run anywhere from $200 to $300 on a retail basis, and there's probably a monthly subscription in the range of $15 to $30 a month. I'm not 100% comfortable or confident that consumers are going to absorb those costs for 3 to 5 virtual visits with a provider on an annual basis. And is there a possibility that we can leverage existing healthcare financial funding mechanisms like insurance to pay for some or all of these devices, knowing that insurers may get a cost benefit through the virtual visit contracting that they have with providers. If you're a provider and you fall under MACRA or MIPS regulations, you now have an opportunity to better capture and record and manage the quality measures and the care gaps that lead to higher MACRA, higher MIPS, and higher compensation, through your Medicare and risk-based contracts with commercial and Medicaid insurers. Next. This category is what I call diagnostics as a service, and I like to think about this as kind of point of care testing at your home. This is kind of the next generation of point of care testing where patients don't have to go to a clinic, but similar to what we've been doing for diabetes for years, Scanwell is one of many companies who's now created a mechanism by which patients can manage UTI symptoms and conditions without ever having to leave their home. So a patient would download the Scanwell app. It's free. They would go to their local retailer, drugstore, and purchase, a Scanwell test kit. The test kit has test strips in it, similar to a take-home pregnancy test. A patient who suspects that they have a UTI would urinate on this strip. Then they use the app to take a photograph of that test strip. And this app, which is an AI-enabled app, can then provide a preliminary diagnosis that it's either negative or it's a suspected positive UTI condition. If it's the latter, then the Scanwell allows the patient to connect to a provider who will review the information and determine that, yes, in fact, this is a UTI diagnosis, and counsel the patient on their treatment options, and including the ability to submit a prescription to your local pharmacy so the patient can fill that prescription and begin their treatment regimen for UTI. So we've now gone from a situation where virtual visits can provide not just physiological information through connected devices, but now we can provide diagnostic information through kind of an asynchronous mechanism like the one I just described. Scanwell is one of several companies that is developing solutions in this space. And for Scanwell, they now have chronic kidney disease, which is also a urine-based test, well into the final research and development phase. And they've just started on a blood-based test for COVID antibodies. I'm going to the next screen. One of the things that physicians are realizing, whether it's a primary care practice, a multi-specialty group, or a healthcare system, is under this new normal where financial and human resources are highly constrained, that they've got to figure out how to bring more automation into their front office, mid-office, and back office functions. The cost of operating a small group practice, even a medium-sized medical group practice, is becoming very, very challenging for these clinicians and their administrators. Notable is a company that I've now seen present at two investment seminars over the last 2 years, and they are making tremendous headway in their ability to help clinicians automate the front office. So the scheduling and the registration and checking in of patients for clinical services, they're making tremendous strides in automating the check-in and rooming process and the capturing of information that medical assistants and nurses would typically do through that rooming exercise, facilitating a more efficient mechanism or way of documenting electronic medical records so that providers are spending more of their time focused on the patient and less of their time, on the technology. And then lastly, they're working on the back office to really further automate the cash flow process for a business and for a medical group. They have existing relationships now with a number of EMR platforms, and there's two of them represented on this slide. But I've been very impressed, not just with what they're doing, but with the progress they've made, the substantial progress over the last couple of years. I'm proceeding to the next slide. Now we're at the point of the care continuum that I refer to as specialty care. Many in this virtual room may be familiar with ECHO, a distance learning program for primary care providers that want to learn how to manage more low acuity, low complexity conditions that might normally be referred to specialists. And I think this is very important as our specialists are being overwhelmed with low acuity, low complexity conditions, and it creates our time to first appointment. It pushes those times to first appointments out to not just days, but weeks and months. Similarly, e-visits, for those that are familiar with it, for those that are not, how do we use electronic communications between primary care providers and specialty providers, especially those that share a common electronic medical record? How can the primary care provider pose questions? How can they get answers without the patient having to schedule an appointment with a specialist that may not occur for months, incur those additional costs, and it really delays the treatment and recovery that they seek. We've talked about virtual originating sites, and as we did on the primary care slide, I think virtual visits have a huge upside for specialty providers. A client that I'm working with right now in the Midwest, the GI practice, when we introduced the concept of doing virtual visits with them, the physician, who is also the chair of the department, said, "Kirk, I think as we sit here and talk about this, I can think of the 20 patients I saw yesterday, all but 2 of them I could have seen virtually, and it would not have compromised the quality or the integrity or the value of the service that I delivered to them. And more importantly, it would open up our clinic-based infrastructure and assets and resources to new patients, and get them in more timely for the services that they need from us." So there's a tremendous opportunity there. Many of you are familiar with clinical originating sites. That's a lot of where telemedicine started. How do we connect patients at a clinical originating site to a distant site specialty? Where I came from prior to launching Constant Horizon, we had a large telehealth program, and we had upwards of 30 originating sites, rural healthcare communities, frontier communities, but also acute and post-acute originating sites. And we had upwards of 30 to 35 specialty and subspecialty distant sites that were participating in the program. And then lastly, quaternary sites. Quaternary sites are also being overwhelmed with what I would call tertiary referrals. And these quaternary sites really want to preserve their capacity for the rare, complex conditions that their academic medical centers are uniquely qualified to treat and manage. But when their schedules are overwhelmed with what I again refer to as tertiary volume, it makes it difficult for them to do that. So how can we implement telemedicine relationships and programs between tertiary healthcare communities and quaternary communities that allow care to remain in the tertiary health system and only refer those patients, to a quaternary system when they are truly qualified and require the services that those academic medical centers can provide, and provide very effectively. We're going to talk about, I'm clicking on to the next slide, and this is titled Digital Therapy. This is, I think, one of the most exciting innovations that's occurring right now in healthcare. And it goes back to the concept, again, that our specialty practices, and more importantly, our medical specialties, are facing real shortages when it comes to physicians and the advanced practice providers that work in those clinics. And how can we use technology to act as a physician extender so that chronic disease, established patients with chronic illness, chronic disease, can be managed by digital through digital therapy mechanisms rather than constantly using clinic-based resources, whether in person or virtually, to provide what I might say is kind of low-value services for these chronic illness, chronic disease management patients. So digital therapy is AI and telehealth-enabled prescription therapy. So these applications are literally prescribed by the physician, and it utilizes applications on the patient's smartphone to treat a disease. This is also referred to as software as a medical device or prescription digital therapeutics. And what's great about this new approach is that the companies that are creating this, they're going through an FDA approval process, which means that the physician has to prescribe these applications as treatment. And as such, if it's a prescribed intervention, I'm hoping that insurance will cover these benefits so that the physician, the specialty practice, can realize the benefit of this physician extender technology, as well as the patient realizing the benefit of the convenience of this technology. But these platforms will support connected devices that are purpose-built for the disease that they're managing. They will connect patients to live clinical support. So telehealth, telemedicine is fully integrated into these platforms, as well as connectivity to pharmacists if patients have, pharmacy management or pharmacotherapy questions, comments, concerns that they need addressed. One of the organizations or companies that's in this space is called Click Therapeutics. And on this graphic here, you can see the number of conditions that they have either in development in the final regulatory approval stage, or they're actually have launched. I'm clicking to the next slide. This is an extension of, again, or a continuation of that digital therapy slide. But on the left, you see a number of conditions, 7 different chronic illness conditions. On the right-hand side are companies, and these are just examples. There are many companies that are in this space right now. And this is an area, when you go back to those investor slides, investors are making heavy-duty financial commitments to these companies to develop this technology. You can go out on the internet and you can look up these companies and read and learn more about them, but they are all operating in a similar manner where it's AI-enabled approach. It's machine learning to make these applications faster and better and smarter and cheaper for the consumers to be able to use. They are all leveraging fully integrated telehealth and telemedicine capabilities. Many of them will also support peer networking, so patients can connect to other patients, other families, other caregivers that are struggling and managing and dealing and solving the same issues. And it's just it's a very fresh alternative to patients having to go to the clinic every single week, every single month, every other month to receive these kinds of services. And hopefully it frees up the staff and the physicians in these specialty clinics to take on more patients and allow them to maybe grow their panels and not just focus on managing existing patients with chronic illness. I'm clicking to the next slide now, and this is the acute care phase of the care continuum. I'm going to skip over a few things here or quickly go over them. I refer to transfer medicine. That's kind of the traditional telehealth model. Patients at a distance are connecting to a suburban or an urban healthcare center to collaborate with the staff there to determine, do I really need to be transferred, from my suburban or rural hospital to an urban or suburban hospital for a higher level of service, or can I remain in my local community and all the benefits that go along with that? Specialty services in the acute environment. I think there's a lot of exciting things going on here. as far as how are hospitals able to use telehealth and telemedicine best practices and workflows to connect with specialists who can provide consultative services virtually rather than in person? How can we connect with hospitalists or hospital medicine subspecialists? It's very common, preaching to the choir, that we have internists staffing the inpatient floors and rounding on patients for all of the medical diseases that are in their facility or institution. But more and more now we're seeing subspecialties like neurohospitalists, psychiatric hospitalists, and being able to recruit, hire, and retain those subspecialists in facilities is a real challenge. And how can we leverage telehealth, telemedicine best practices to connect to these resources on demand, which may be a better utilization of our finite financial resources, but may also help us overcome some of the human resource barriers associated with recruiting, hiring, and retaining these types of subspecialists. And lastly, something I'm really passionate about is call coverage. If you're a physician, in a community that's got multiple hospitals, you have privileges at multiple hospitals, the challenge for meeting the call obligations are overwhelming, and the quality of life for those physicians is not very high. So again, how can we use telehealth best practices to virtualize call coverage? And even if 30% of those 2 a.m. phone calls, which normally result in a physician coming to the emergency room, coming to the hospital for a condition that could have been seen the next morning or the next day, that improves the quality of life for that physician immensely. And I think we should be doing everything we possibly can, to modernize our hospital policies and procedures to support the use of telemedicine to virtualize call coverage as much as possible. I think many in this virtual room, many in the industry are also familiar with how we're using telehealth, telemedicine cams in newborn ICUs, how we're using them in cardiac, medical, surgical ICUs. I think that work is fantastic. And it kind of goes back to the same concept that we've got to get to a point where one resource can manage many patients, many families, many caregivers at a time. In this case, ICU beds, and being able to connect those patients with family members outside of the institution so they can be part of their care and part of their recovery, knowing that they're going to come home. Same thing with e-sitting. Fall risk is a really important quality measure for hospitals. It's also a significant contributor to length of stay and complications and mortality in hospitals. And putting nursing assistants or other technicians in a room to monitor fall risk patients is not scalable, it's not sustainable. And how can we use technology to do that more efficiently? I'm going to click to the next slide to talk about something that I'm really excited about in the acute care phase. And this is referred to as emergency triage, treat, and transport. Again, for those of you that are familiar with the EP3 programming, I apologize. I think this is a well-kept secret, unfortunately. And it's finally, there have been a number of kind of EMS or paramedic organizations across the country that have been developing community paramedic programs and mechanisms for trying to treat and manage patients outside of the hospital environment, or to try to avoid transporting patients to the emergency room when what they really need is transport to a mental health, a detox, or an urgent care setting. So after years of kind of groveling with Medicare on this subject, CMS has approved a 5-year payment model that's in the rollout phase as we speak. It's designed to promote a more efficient use of healthcare resources, and it's really designed to facilitate sustainability or greater sustainability for urban and especially rural and frontier EMS programs. These rural and frontier EMS programs that rely on volunteer support are really operating on vapor right now. And how can we provide them with the additional compensation that they need to provide these kinds of services in their local communities? So what does the reimbursement cover? Number one, it's triage. So what these communities are able to effectively do now is use their 911 call system. Hello, you've reached 911. How can I help you? Do you need, fire, police, or medical? Transfer you to medical. Instead of the operator just saying, where are you located, and I'll dispatch an ambulance, let's put you through an evidence-based protocol that will effectively triage the patient to determine whether or not you need to be transported, whether or not you can care for yourself, or whether or not you need a paramedic to show up and do something with you. So this triage mechanism, which exists in a number of communities right now, but it's uncompensated, is now going to receive some compensation from CMS. We're also advocating, this also advocates a treat and release mechanism. So if a paramedic is dispatched to the patient's home, in this example, they would have the ability, using pre-existing protocols and working under the guidance of a medical director, to be able to treat the patient in place and release them without having to transport them to a medical facility. And again, they can then drop a claim to Medicare and get reimbursed for these services. And then lastly, as many of you are aware, that these EMS organizations kind of derive 100% of their compensation by transporting patients to emergency rooms. And it puts undue strain on emergency rooms when upwards of 40% of those patients don't need to be seen in the emergency department. So can we transport them to alternative destinations like mental health facilities, like detox facilities, like a doctor's clinic or office, including urgent care? And can they bill and get compensated for those transports when the patient doesn't have their own mechanism for getting transported to those institutions? And what's pertinent to this group is the fact that the regulation, the policy that's implemented by CMS specifically calls out coverage for technology-enabled care, including telehealth and telemedicine. So when that medic is on site and they are trying to determine, if I can treat and release, or what is the appropriate destination for this patient, they can connect to a clinician at the local sponsoring hospital or their medical director and be able to conduct a telehealth visit on demand to facilitate and expedite this transaction. More to come on this. I'm clicking to the next slide. Post-acute care. Again, this may be rather preachy, so I'm going to skip over some of this rather quickly so we can get back on schedule here time-wise. But I think many of us are aware that we're doing telemedicine from skilled nursing facilities, rehab facilities, home health, hospice. I think what's interesting here is most of the programming that I've seen is a patient is in stress and we need to reach a clinician in order to avoid having to transfer or transport the patient, back to the local hospital, and to avoid, a readmission penalty for us, the post-acute facility, or our sponsoring hospital. And that's fantastic. I support that 1,000%. What I think is even more exciting from a post-acute setting environment is when patients are discharged from the acute to a post-acute setting, most of these patients have a number of comorbidities that are actively being treated and managed by providers and multiple providers and multiple specialists. And my experience tells me that much of this kind of elective, scheduled clinical encounters with providers involved in the management of these comorbid conditions for these post-acute patients is done through kind of a carbon-based model where we load patient or patients into a van and drive them around town for 4, 6, 8 hours so they can go to all their doctor's appointments. I rarely see specialists rounding on patients in these post-acute environments. And these post-acute environments, the way they make money, is providing treatment, providing therapy for patients when they're in their institutions and in their facilities. When they're being driven around town, they can't provide those therapies. They're not able to bill for those services, and it puts undue financial stress on those organizations. So how can we not just do kind of urgent on-demand telemedicine from these post-acute environments, but how can we do elective, scheduled telemedicine for patients that are recovering from a stroke, but they also have diabetes, or they have other conditions where they need to see their physician on a recurring basis until they're discharged to home. So we're really focusing on how can we do scheduled telemedicine out of these originating sites, not just on-demand telemedicine. Proceeding to the next slide, and this is simply, yep.
We are actually out of time, and we do have a couple of really good questions. I don't know if you're comfortable with kind of switching gears, and if folks can hold on for just a couple of extra minutes. I know I'm good to hold on if you are, Kirk, and we can maybe answer a couple of questions.
Happy to.
Okay, awesome. So this is a great question, and a tough one maybe to answer, but how do you plan in advance for some of these ideas? And like the urinalysis testing kits comes to mind. I think that's when this question popped up, to be available before the patient needs it.
So it is a good question. When you sit down with a company like Scanwell and they present all the data, patients that have UTIs, it's not where a patient has one UTI, they don't just have two UTIs. I mean, these patients they have recurring urinary tract infections that on a recurring basis are driving, costs and disrupting their lives from a family and employment perspective. So I think who are the high utilizers of care, what kind of conditions are represented in those high utilizer profiles, and then are there technology-enabled solutions in the market to help reduce the demand or to help improve the access, the quality, the affordability, and the convenience for those patients and families. But I think it's really a data-driven analysis that leads to pursuing the right technology to solve the right problem.
Great, thank you. So maybe time for one more question, guys. And folks who can hang on, please do so. I am managing virtual care for an organization in a rural area of North Carolina, and one of our biggest issues is patients with Wi-Fi connection and even provider Wi-Fi connections when working from home. How can we solve this problem that I imagine so many rural areas are experiencing? Oh, are you there, Kirk? I can kind of field that one, guys, if you'd like. We certainly have been getting a lot of this with, as the telehealth resource centers. There's a lot of funding that has been out there, but historically it's been for healthcare organizations, right? We're not used to people being at home, providers and or patients. And so adjusting funding mechanisms, like federal mechanisms, to that is certainly been slower. However, the FCC just wrapped up a large $200 million funding opportunity that we'll see, if this pandemic continues to go on, I would imagine that they may find additional funding to put out there that would actually fund Wi-Fi enabled devices for patients' homes, for providers to use at home, to really adapt to that home as the originating site, or the patient site, or the provider site, et cetera. The other piece is policy. I can certainly speak to a couple of our states here in the Northeast who just passed massive bonds. Maine just passed a massive bond for investment in broadband capacity specific to rural areas in Maine, because it's just like in North Carolina and any other state who has very rural areas, remote areas, it has consistently been an issue. In our rural areas, there are also areas for tourism, et cetera. So it's not just about healthcare. So I think the more we can get our partnership, our multi-sector partners involved in changing policy, or making sure that there's funding at the state level, at the federal level, even at the community level, municipality level, we see a lot of that going on, to really invest in broadband. I think we've certainly learned from this pandemic that it's so important. Digital health, business, et cetera, is so important to our livelihoods, our productivity, our health. And so to really invest in that, whether you're, advocating or lobbying for something like that within your state, is a way to start to help address that. Kirk, are you back with us? Okay, I think we might have lost Kirk, and since we are out of time, guys, I want to thank you so much for your patience as we had a little bit of technical difficulties at the end. Thank you so much again for joining us. I think we may have lost him, but I want to thank Kirk Gillis again for sharing. That's amazing, some of the things that are evolving in the space, and we thank him for sharing all of that here with us today. I hope you are able to join us for the second session and for our virtual exhibitor hall a little bit later this afternoon. As always, if you could take just a minute to go ahead and complete the evaluation of the session, that is super helpful for us. And thank you all so very much, and we'll see you again soon. Bye-bye.